So I am so excited to be here with you guys today. This is my first SCAGO conference. I am located in Detroit, Michigan, so we are very close to you guys and should be much more connected and collaborative with the work that you guys are doing. But I'm just so honored to be here today. I want to know a little bit about who's in the audience. If you are a person living with sickle cell disease, could you raise your hand? So I'm going to give you guys a hand. Because this is all about you at the end of the day. And I think it's important in a complex world where all of these things are going on that we're gonna talk about some today. I think we have to keep our North Star in mind. And when I think about my North Star, it is the people living with this condition is why we're here, why we do the work that we do. And when I think about that, it motivates me so much when I look at you guys in terms of how can we collectively make a difference. If you are a healthcare provider, physician, nurse, whatever capacity that takes care of people living with sickle cell disease, could you raise your hand? So I want to thank you all. Because I know the work and the commitment and the dedication that it takes to care for people living with sickle cell disease. I thought that when I was in my medical training at University of North Carolina with my friend Donnell Ivey back here, we were in medical school together at UNC Chapel Hill. Lots of stories that we'll keep between us, but I thought I was going to be a hematologist. I was in a lab that studied blood function and red blood cell health, and I knew I was going to be a hematologist until I realized that I was not cut out for outpatient medicine. And I found that my place was in the inpatient world, in the ICU setting. And one of the things we began to see is that sickle cell disease needs friends across many disciplines, not just hematology, but cardiologists, intensivists, cardiologists, nephrologists, pulmonologists. And so it's been wonderful to see the expansion of interest in sickle cell disease across disciplines. If you are an advocate for people living with sickle cell disease, can you raise your hand? I want to thank you all. Because so much of the work that we do could not happen without you. Because you guys, whether it's popular, whether it's funded, whatever's happening in the world, you guys stay committed in making sure that the focus is on the people living with sickle cell disease and we're doing the right thing. And finally, if you are in industry, could you raise your hand? So thank you guys for what you do. Sometimes, especially coming up as an academic, you kind of view industry as like, back in the dark ages when I was coming through grad school, as going to the dark side, right? But the reality is that much of the innovation that I'm going to talk about today and that's happening in sickle cell disease could not happen were it not for the investments that are made and the work that's happening in industry to take the basic science, the things that we learned, and actually make those actionable. You guys are where the rubber hits the road and where these innovations actually reach patients. So I want to thank you guys for what you're doing as well. So now that those thank yous are out of the way, my mom always told me that it is important to thank the people who really do the work. So I wanted to make sure I recognize folks. The title of my talk today is Modernizing Sickle Cell Care, Reimagining the Treatment Model from Crisis Intervention to Health Maintenance. And that's going to be a theme that we're going to talk about throughout the day, reimagining, which means that whatever you see today, whether you're a person living with sickle cell disease, a person caring for people with sickle cell disease, an advocate, a parent, a family member, industry, let's not lock ourselves into what is available today. Let's imagine a world where we can make progress and make things happen even if we don't necessarily see them today. And that's really the point of the talk, and I hope that I communicate that well to you guys as we go forward. I want to talk about conflicts of interest. So although I'm an academic professor of pediatric critical care at Wayne State University, One of my interests has been, how do we take this stuff that we learn and we make it real in the real world? And so one of the ways that I've done that is I've spun a startup company out of my academic laboratory called Functional Fluidics. So Functional Fluidics is a biotech company that develops red blood cell function assays, some of which are going to be referenced, I'm going to refer to in this talk. But the data presented are from peer-reviewed publications and presented abstracts. No product endorsement is intended or implied. So I think it's always important for all of us to think about, why do we do what we do? And when I think about why I do what I do, I think about back in the mid to late 90s when Donnell and I were in medical school at University of North Carolina. My younger sister was at North Carolina A&T University, which was about 45 minutes up the road. And I remember I was studying for our medical school exams. And I was telling my colleague Nadine, I can be in an ICU with all kind of crazy stuff going on, but exams were always something that produced a lot of anxiety. So I was, really focused on that. And I got a call from my sister about her boyfriend, Eric. This was her first boyfriend, and by definition, I wasn't a fan because he was dating my sister. They were 19 at the time. Young theater majors, just exciting life ahead of him. She calls and says, Patrick, something's wrong with Eric. I don't know what's going on, but he's having pain, and I'm going to take him to the ER. I just wanted you to know. I think everything's fine, but I just wanted you to know that we were doing that. 15 minutes later, she called again and said, they're admitting him to the hospital. I don't know what's happening, but I'm getting kind of scared because all of these doctors are in the room and they're saying that he's having pain, they can't control it. And so now I'm getting concerned. And literally 10 minutes later, she calls me back and says, he isn't breathing. And there's a room full of doctors and nurses that are here working on him. And they push me away and I can't even see him. And so Greensboro is about 45 minutes from Chapel Hill. I got there in a half an hour. I was in the room. And when I arrived, Eric had passed away. And what happened was this young man who was transitioning from pediatric care to adult care as essentially an adolescent in college, wanted to shed the label of being a person living with sickle cell disease, because at that time, there were no therapies, right? This was pre-hydroxyurea. And they did not realize he had sickle cell disease at the time because he hadn't disclosed it. And he was oversedated, had respiratory depression, cardiac arrest, and he passed away before they realized what was happening. One of the questions that I asked myself, because at this time I had already done a rotation in a lab that was working in sickle cell disease, and so I knew that this is something I'm really interested in. I'm fascinated by red blood cell biology, but now I'm looking at this young man, and it really became real. And the question I asked myself was, why do we wait for the crises to tell us that the patient is in trouble? Why I'm learning about all this stuff in medicine, and we predict, we prevent, but when I learn about this condition, we react. And that just didn't seem right, and that didn't sit well with me in 1997, and it still doesn't sit well with me today. So I want to describe two models of care that one represents what looks more familiar to us today, and then the other represents where I think we can reimagine. And again, that concept is going to repeat itself throughout this conversation. So crisis intervention, this is kind of where we've been. This is what happened with Eric, where pain is the alarm that there's injury. But it doesn't necessarily have to be the thing that alerts us that there's action that needs to be taken. Care is triggered by in an emergency department. Severity is judged oftentimes retrospectively by events already suffered. Therapy is adjusted after damage accumulates. Silent organ injury proceeds unmeasured. Whereas in a health maintenance model, where I think we should be figuring out how can we get to a model that looks more like this, where blood function, right? We understand that the fundamental part of sickle cell disease is a defect in blood function of our red blood cells. And so why can't this be the alarm? And this be something that we can measure before the actual event takes place, where care is triggered in the clinical setting, in the steady state, much like we do a blood pressure. Risk is stratified prospectively on using an objective number, not a subjective description of an event. Therapy is titrated and measured to a response, and health maintenance becomes the goal, not counting the number of crises or events that a person has. That's what I think we can reimagine. Again, I'm an ICU physician, and so people think that your job is to manage crises and to manage emergencies. No, actually, what I tell my trainees is our job is to prevent that stuff from happening. That's our job. And so we monitor a lot of numbers to understand the people that we're taking care of with the goal of preventing these things from happening. So with cardiovascular disease, hypertension, we have a blood pressure. And if you can imagine back in the 60s and late 70s, when this was not commonplace the way that it is, we were reacting to cardiovascular disease much like we react to crisis pain today in sickle cell disease. But now we think about blood pressure as the surrogate that we treat and ensure that even if you're at steady state and you're well, we keep that blood pressure normal to prevent that event from happening. And what that's done is not only improved the outcomes of people living with cardiovascular disease, but it's actually revolutionized the ability to develop therapies that are meant to keep blood pressure low, not necessarily to focus on that event that we want to avoid. Similar concept with hemoglobin A1C and diabetes, LDL and atherosclerosis. We don't have that in sickle cell disease yet today. And it's not because work hasn't been done, but historically the clinical endpoint has been the crisis itself. Debilitating pain and organ dysfunction has been that signal. But my thesis has been that sickle cell needs its own hemoglobin A1C, its own blood pressure, its own LDL, to really understand the risk before the clinical event actually happens. And that's really been the focus of much of the work that I've done over the years. So counting cells versus measuring function. So a lot of times when I talk to groups and we talk about the data, I'll hear from folks, well, we already have numbers in sickle cell disease. We can count the number of red blood cells. We can measure the amount of hemoglobin, right? So for example, hemoglobin can tell us how much of this oxygen carrier is present. A reticulocyte count, it reflects how hard our bone marrow is working. That's important information. The hemoglobin differential, the percent hemoglobin S, percent hemoglobin F. This is a genetic and therapeutic context for the condition. LDH, bilirubin, can help us understand how much hemolysis has occurred, not necessarily the risk of hemolysis, but how much of this has actually occurred. All of this is a snapshot of quantity taken in a test tube at rest. But what don't these metrics tell us? They don't tell us, will cells stick to the inflamed vessel wall? Can they bend and flow through a narrow capillary at the point where it has to actually deliver oxygen to the working cell or tissue that needs it? Will they survive mechanical stress when this blood is circulating from our blood, from our heart, to our arterial circulation, to our small vessels where they deliver oxygen back to our veins, back to our heart, back through our lungs, over and over and over again? Do they survive that stress, or do they hemolyze in response to it? What's the impact of stress, such as hypoxia, whether it's through altitude, through nocturnal hypoxia when you're sleeping because of obstructive sleep apnea, or infection where we have a lot of local areas of hypoxia? How do those red cells that are present respond to that type of stress? Are red blood cells better or worse now than they are in 3 months based on therapy or just based on the natural course of the condition? Much like blood pressure, much like hemoglobin A1C, and much like LDLs. Vaso-occlusion is a physical event and deserves a physical measurement. So putting red blood cells through real-world conditions has really been the focus of a lot of the work I've done over the years. Standardized laboratory-based assays that stress red blood cells the way that the circulation does, and then returns an actual actionable number. Adhesion. So we talk about red blood cell health, but we oftentimes don't really get into specifics. We talk about it conceptually, but I want to kind of, take time to really talk specifically about what we mean. And so when we talk about red cell health, I think the first thing to think about is, what is a red blood cell supposed to do? And the red blood cell is, to me, the most fascinating cell in the body, the most important cell in the body. It is the largest component of our circulating blood. Delivers oxygen to every working cell and tissue in our body. So whether you have sickle cell disease, cardiovascular disease risk, or any condition, it is a critical, fundamental component of our health and wellness. And so delivery of oxygen, everybody understands that that is a very important part of what red blood cells do. And to deliver oxygen, they have to get to every part of our body that requires oxygen to survive. The other thing red cells have to do is actually the absence of things, right? So red blood cells, because they're so populous in our blood, they should not interact with white blood cells and cause inflammation. They shouldn't interact with our blood vessels and cause obstruction to blood flow and obstruction to oxygen delivery. And they shouldn't interact with our coagulation system to make us more prone to clotting. So some of the properties that we can measure to objectively assess the health of red blood cells are things like adhesion or stickiness of red blood cells, which we've shown, and I'll talk about some of our data in the next slide, is one of the first blood-based biomarkers to stratify people in steady state with sickle cell disease according to the risk of having a future pain event. Very exciting data that I'm going to talk to you about a little bit later. Deformability. Red blood cells have to be able to squeeze and twist through these small diameter blood vessels to get to where they need to go. Membrane stability. So in your red blood cells right now, if we were to take a sample of blood from you, we can understand the risk that those red blood cells have to break down and to hemolyze before the hemolysis actually happens. And hypoxic response. So it's not just a static measurement, but it's the assessment of how do these red blood cells respond to certain stressors like hypoxia. There's many other stressors that we can think about as well, but that's important. So together, these metrics describe red blood cell health, not how many cells a patient has, but how robust or how fragile these cells are today. I was on the 401 coming to Toronto last night from Detroit, and I timed it based on 3.5 hours to get here. I was going to arrive at about 10 o'clock, get some sleep, and but I ended up getting here at 1 in the morning. And why I get here at 1 in the morning? Because the analogy to red blood cells in the circulation are like trucks on the 401. And there's parts of the trip where there was a lot of trucks there, right? But we were moving just fine. So if you were just to count the trucks, you may think that we're in bad shape, but we're actually moving okay. It was when one of those trucks stopped and blocked transit that we had problems. So I think about it much like that. It's the function, not necessarily the quantity, that's important. So some of the data that we did a study called the Ellipsis study, where we looked at a population of patients over time. We asked those patients to tell us when you felt like you were in steady state and when you felt like you were in crises. We didn't have a physician or a nurse tell us this. This was directly from the patients. While we were doing that, we were assessing their red blood cell health parameters, specifically adhesion. And we assessed it at their steady state. We assessed it when they said they were having a crisis. What we learned was that when an individual is at their steady state, and their adhesion or stickiness indices to something called vascular cell adhesion molecule, or VCAM1, and P-selectin were above a certain threshold, that they were at risk for having a future event that we could actually predict. And so at the bottom, if you look at these patients here, so if I were to poll this room or test everybody in this room, a portion of you guys would be below the threshold. A portion would have one of these metrics above the threshold. A portion would have both of these metrics above the threshold, although we're all sitting here feeling fine. Why is that important? Well, if you have both of those metrics above the threshold, your median time to your next crisis event could be as short as 10 days. If both of those metrics are below the threshold, the median time to your next crisis event could be beyond 100 days. So that kind of now gives us a model where we can think about red cell health in the context of other chronic diseases like cardiovascular disease and diabetes. So quickly, 19% of individuals at any given point in time, approximately, when we did a real-world study of about 1,000 individuals in 4 states in the U.S., had baseline adhesion metrics above this threshold, which would predict that they would be at increased risk of having a future crisis event while they're at steady state. So different mechanisms, one readout. So another area where this is important, we talked about with diabetes and cardiovascular disease, where we've done a lot to develop therapies. So when I'm taking care of these patients, I have so many different therapeutic options. But when you're taking care of people with sickle cell disease, we have actually reduced the number of therapeutic options that we have available, given some of the things that have happened with approved therapies and in the context of clinical trials. Crizanlizumab is an example. So this is a P-selectin inhibitor. We've shown that individuals that have elevated levels of this adhesion index are the best biologic responders to crizanlizumab, which makes sense. It is an inhibitor of an adhesion molecule called P-selectin. Similarly, with a different red cell modifying therapy, osivelotor, which increases hemoglobin oxygen affinity, which reduces sickling, and overall improves the quality and health of the red blood cell over time, we see similar improvements in red cell biology, particularly in folks that have the most abnormal red blood cell metrics to start with. And then in gene editing, we've done some really extensive studying in establishing the baseline red cell health metrics and the response, the biological response to gene editing, which has been really important in helping us understand how these individuals respond. So the path to getting a qualified biomarker helps us understand why we don't have those available right now. So there's a regulatory path where we're talking to the FDA about a letter of intent, qualification plan, full qualification, clinical adoption. It's a lot of work that takes years to do. We're in the process of doing that, but it's a significant amount of work to get there. Now, going past Eric, I want to talk about another individual briefly with sickle cell disease, and the number I want you to keep in mind is 19,341 feet. That is the summit of Mount Kilimanjaro, where the oxygen content, unlike the 21% oxygen we're breathing right now, is about 10 to 11%. In 2024, Jimmy became the first living person with sickle cell disease to summit Mount Kilimanjaro. And thanks in large part to our friends at Vertex Pharmaceuticals, he received the Casgevy treatment, gene editing, which allowed him to be able to transition from a life of constant pain and fatigue to a life where he was living essentially a normal existence in the context of being at sea level in Atlanta. But when he volunteered to participate in this climb, we had obvious concerns because no one had really tested the limits of how red cells can respond to stress, even in the context of increased fetal hemoglobin. So we measured some of these same metrics before the climb. So we measured his adhesion indices, which were completely normal, which we would expect. But then when we stressed him in terms of the blood sample and we exposed it to hypoxia, despite the fact we had about 50% fetal hemoglobin, about 99% fetal F cells, we could induce those cells to sickle in oxygen levels that were consistent with about 15,000 feet. And when we were on the mountain, we actually saw jaundice and hematuria when we were at 15,500 feet. The difference is we had assessed this a month ago. We used that month to come up with a very extensive plan to manage him on the mountain, and we're able to engage with him. We had plenty of extra oxygen. We had a plan for hydration. We were able to get him to the summit safely. And at 9:41 in the morning on September the 22nd, he became the first living patient to summit Mount Kilimanjaro. And that is one of the greatest, I think, achievements in terms of academics, advocacy, industry coming together and doing something amazing for people living with sickle cell disease. So I'm getting close to time, so I'm going to move quickly through these last slides. So the ceiling was not assumed, it was actually measured. Function is the outcome that matters, right? Not just the amount of hemoglobin and the amount of cells that he had. And monitoring turned that hope into an actual plan that allowed us to be successful in helping him to achieve that goal. So how do we put this together in terms of a maintenance pathway for sickle cell care? So the vision is we want to be able to provide the ability to measure these metrics, stratify individuals according to risk, intervene when necessary based on biology, not based on assumptions, and then monitor the response biologically, not just based on how one feels. And then this is a loop where you continue this process the same way we do in other chronic diseases like cardiovascular disease and diabetes. And getting this metric to the clinic, again, is going to be a long road. We did a 4-year pilot in 2019 where we looked at about 1,000 individuals, over 25,000 tests. So with this 4-year pilot, we learned that it was feasible, that providers could order it, that they could understand it, that they could act on this information. And so that was an important part of what we had to do. That evidence generation, we were able to talk about that evidence, publish that evidence, and now put that in front of regulators to be able to think about. And now the next goal is to have staged access to these tests in the clinical setting, not just in clinical trials, starting in 2027. And so what changes? So if you live with sickle cell disease, the goal is to be able to understand what your baseline is and ask whether it's moved after a treatment. And we believe that you're entitled to an objective number, not just a narrative. If you're a hematologist, we think that it helps you to understand the dimension of that a CBC can't give you. Who to escalate, when to act, whether the therapy you choose is doing anything biologically. And if you're a family physician, it gives you the opportunity to think about this in the context of a steady state patient. And if you're an advocate, then it gives you an opportunity to really think about how to put more control in the hands of people living with sickle cell disease. And so this is really what we have been working on and what we've been trying to do. And I'm really excited that we've been able to make a lot of progress here. So in closing, I believe that the generation being diagnosed today with sickle cell disease should not have to earn care by surviving a crisis. I want you to sit with that for a little bit. More therapies have arrived in the last 6 years than over the previous 60. And we have lacked the measurement layer that tells us who needs these therapies, how they're working, when to act, and that layer is what we're trying to build right now. So the work began with Eric back in the mid-90s. Jimmy showed us that this can actually work. And the next patient is the reason why we got to keep going. So thank you so much for your time, for your attention. I'm really excited about this conference and being able to hear all of the things that we discuss and talk about. And I encourage you guys to work together and so we can improve the lives of people living with sickle cell disease. Thank you all very much.